Hello everyone, good evening. I'm Io, Addiction Medicine Fellow at Vanderbilt Order, and the part of my talk will be going over screening and the definition, as well as how to make the diagnosis and then treatment options. So that's the part that I will be talking about. This is the outline that we're going to go with, just what I just went over, and at the end we'll look at some biomarkers for tracking treatment, how folks are doing when you have them on treatment for AUD. I have nothing to disclose. This is all for educational purposes. And so first out, we want to look at the statistics on alcohol use disorder. Right now, about 29.5 million people in the US are diagnosed with alcohol use disorder. And out of that, that is from age 12 and up. And if you want to look at the adolescent age group as well, you can see that about 894,000 have the diagnosis as well of AUD. So it is a lot of people, and we see them just about on a daily basis. We do treat them daily, and even in your own practice, you may see these folks as well, whether you are in a primary care setting or in GI setting. Most of the time you will see folks come across that do drink in some form. And how are we doing to treat these folks? At this point, in 2021, only about 10% of people with AUD was getting some form of treatment. And most times, even if they were getting a treatment, the treatment did not include medicines. It was only like a therapy or counseling, but we need to look into how to incorporate some medicines in the treatment as well, and that is part of what we are going to go over. So we're treating very small fraction of that number, and we need to get the number a lot more higher to help folks that are needing the help. This slide here was just to show us some of the things that people like about alcohol and some of the things that come across our mind when we think about it. So it's not all bad, but it's bad when used inappropriately. So as we can see here, often for social events, people drink alcohol. It's an acceptable form of socialization. At weddings, things like that, people drink to have fun and have a good time. Also, people like to buy them and collect them at homes as well. They keep it as a prize. Okay, I bought this, it's been around for 5, 10 years, 20 years. People like to collect drinks as well, and eventually they will drink it at some point. So that's what this slide was meant to show. So this is something that folks enjoy, but when not used well, it can turn out to not be good. And on this slide, it was meant to show some of the bad side of drinking. Accidents. People get into arguments when they drink, not able to control emotions and things like that, and violence leads to people losing jobs and housing, and trouble with friends and family, and even going to jail in some cases, or having trouble with the law. So all of that can happen, and we need to be aware of that too. What is the definition of AUD? So it's a medical condition whereby the person doesn't have the ability to control or to stop a drinking habit that is causing social, occupational, or health issues. So when folks drink and they start having some issues, either with their health, with their job, or even housing, like I mentioned, then it can, at that point, start to be a problem. So that is the definition. This slide here was to quantify what is a standard drink, because we'll see how that is going to play in here in just a little bit. A standard drink is 12 fluid ounce of beer, 5 fluid ounce of wine, and 1.5 fluid ounce of spirit or liquor. So if you were to say, someone said I drank 1 can of beer or 1 bottle of beer, you do want to know what was the size, because it could be a 40 ounce, which is well over 12 fluid ounce, and you want to know what size of drink that they're having. And we'll see how that plays in here in just a minute. And then for women, a safe drinking, it's about 3 of those standard drinking in one day. It shouldn't be more than 3, and not more than 7 in 1 week. Then for men, it shouldn't be more than 4 and not more than 14 in 1 week. So when you speak with your patient and folks, you do want to let them know what is safe drinking, and tell them what these numbers are. That way they can know and can keep it in mind that, okay, drinking 40 ounce or 24 ounce, maybe going over the limit. So we should keep that in mind. And we have some, other drinking habits and patterns as well that I did want to point out. Binge drinking and heavy drinking. Binge is when a woman drinks more than 4 drinks at one sitting. As we can see from the previous slide, a safe drinking was 3. So when they drink 4 and more at one time, then it's binge drinking. And for men, it's 5. So just going over that limit. And then for heavy drinking, when a woman drinks 8 or more at one sitting or at one time, and for male, 15, then you're looking at heavy drinking, pattern. So that's what we need to be aware of as well. And this here was just to show us the blood alcohol concentration that is legal in the state. Is 0.08. If you have a number that is higher than that, then you can get in trouble with the law. And over the age of 21, if under the age of 21, then that number changes to 0.02. So we should know this and keep it in mind as well. So we are now on to screening for alcohol use disorder. We should screen. Screening is one of the first steps that we're going to do to catch things early and take early interventions. We should screen at every visit. We should screen at wherever we get a chance to. There are a couple of tools that we can use in screening, and one of them that I want to point out is the AUD C screening tool. It's fast. It's a 3-question screening, as we can see here. How often have you had a drink? How many drinks do you drink in one day? And how often have you had 6 or more drinks in one occasion? So very quick screening. It can take less than a minute of your visit, and then based on what the answer is that you get, you can start to identify alcohol misuse or issues down the road and take appropriate intervention. And these are all backed by studies. We have the longest screening as well, which is the audit tool. Is a 10-question tool. Sometimes folks says, I don't have enough time to get that in, but you can do the audit C, which is a 3-question screening tool. On this slide here, we have some other tools that I wanted to point out that you can use if audit C doesn't work for you and you want to use something else. We have some other tools. The ACE2BI, BSTAD, they all screen for alcohol, as you can see on that tab there. So you can use those as well. And CRAFT is also used to screen for alcohol and other substance uses in adolescent population too. Now we on to how do you make diagnosis of AUD. We go by the DSM-5 criteria. There is 11 things that you look for. They don't have to have all 11. But these are all of them. If they have 2 to 3, they're mild. That will be on the next page. 2 to 3 is mild. 4 to 5 is moderate, and 6 and above is a severe AUD. So you just look on there, see what they meet, see what they don't meet, but based on the number that they meet, then you can say, okay, this is mild or moderate, or it's really bad. Then now what do I need to do next, which will get to the treatment options. What are the risk factors for AUD? Early age, when drinking started, it's a big risk factor. A lot of people drink, but not all people have issues with alcohol. Some drink safely, and some eventually it can lead to AUD. Family history, let's say mom or dad or brother, someone in the family, if they have a history, then the person is at risk as well. So you have to let people know that. Other mental health conditions as well. That's another thing too. If someone is struggling with anxiety and depression, they may tend to look for other things to use and cope. So you need to be aware that that is a risk factor. And if they're having alcohol misuse, patterns and behaviors, binge drinking or heavy drinking, things of that nature, that puts them at risk for AUD. On this slide here, it was to point out all the negative things that can happen from drinking and AUD. It's a lot. And liver disease is right there, which is part of the reason why we're here. A lot of folks that drink, if they drink long enough and hard enough, will end up with some form of liver pathology, and that's when eventually they will come to see you in the GI wall, and then you can take care of them at that point as well. But lots of other things, motor vehicle crash, family issues, missing work, loss of income, and things of that nature. This slide here was to point out when and where do you meet folks. You can meet folks when they are acutely intoxicated and they need to withdraw. So you need to be aware of, okay, this is someone that I need to send to ED to be managed for withdrawal, or this is someone that I can see in the clinic. So if someone comes and they look like they're about to withdraw, you need to be able to recognize it. It was just to go over what can be done. So initially you can use what is called a CO scoring and monitor their signs and symptoms of withdrawal. And that's when you know when to treat when to treat that with a Valium or Ativan or Librium. Those are benzos. Those will be your first line in treatment for withdrawal that is severe. If the benzos look like it's not working or not getting the job done, you can switch to phenobarbital. That's an option. It's just to know that that is there. And if that doesn't work as well, then you may have to send these folks to a higher care, to maybe the MICU or somewhere, to be placed on Presidex or something of that nature. And then you do want to supplement for magnesium and folate and thiamine, and also multivitamin as well. The first 3 days from the last day of drinking is when you need to be worried most, because that's when they can have a seizure or they can get what is called DETs. So you need to be watching closely and be worried. So always ask about when was the last drink. Based on the last day that they drank, then you know if you're out in the safe or if you need to take other options. Long-term treatment. You can treat with medicine, you can treat with therapy, and you can also do some support groups and counseling and things of that nature. I will be going over the medications. There are 3 medicines approved by the FDA for treatment of AUD. Now, Trexone, acamprosate, and disulfiram. Those are the 3 medications. Now, Trexone is the first line, available in oral and long-acting injectable form, which is called Vivitrol. Most of us have heard about it. It's an opioid antagonist, and it works to curb the craving of drinking. Doesn't make you feel like you want to drink. Maybe it doesn't make it taste as well, of get that pleasure that you get when you drink. So eventually it curbs that drinking, and you drink less and less, and hopefully maybe not drink again. Half-life is about 4 hours. It's metabolized in the liver, so you do want to check the liver function. And if their liver function is not good, then you have another option, which we are going to talk about next. And the dosing for that is mostly 50 mg a day or 100 mg every other day. And always be aware, cannot be used if someone is on opioids, because it's a opioid antagonist. So if they have pain and they need opioid pain medicine, this is not an option for that patient. And also know when they last use an opioid when you want to start it. That way you don't make them go into a withdrawal when you get this started. So just some things to know about that. The next choice is acamprosate or Campral, also available in oral form. This is a glutamate antagonist. It's a 3 times a day medicine, dosing in 666 mixed TID or 323 mixed TID. And if the liver function is not good, you can use this, but you cannot use this if the kidney function is not good, because it's renally excreted. So at least you have 2 options that you can choose based on who you're working with. And then the third option is disulfiram. This is not used a lot. It's still being used, but it's an aversive medicine, meaning people take it and they should not drink when they take this, because it's going to make them feel really bad and feel sick. So you need to let folks know, do not drink if you take this medicine. And also don't take it in the last 12 hours that you've had something to drink. It's still gonna make you feel sick. And if you drank something, wait about 2 weeks after to, if you took this medicine, wait for 2 weeks to drink, if you wait to drink, just so that you don't get sick and feel sick, because it will do that. Cannot be used in folks with CAD and cirrhosis because it causes hepatotoxicity. So things to keep in mind. We don't use this a lot, but it's there, and I've seen it being used as well. Other medications that has been shown to have some benefit in AUD, Topomax and gabapentin has been shown to have some benefit. It has been used. It has not been approved by the FDA for that indication. However, it still needs some more studies to support its use. And the other ones that has been used as well, doxycycline has been used, especially if they have PTSD as well. You can use that. There is some evidence for its use as well. And you have to use it at a high dose, and mostly use it at night, because it can cause some orthostatic hypotension. Keep in mind about the co-occurring disorders, and also know that sertraline and fluoxetine has been shown to have some evidence as well in AUD. And also on dansetron as well has been shown to have some evidence. And this would not all be your first line choices, but if you were to be looking for other options, this is all to know that they are there if things goes that route. And on this page here, baclofen has some evidence as well in cirrhosis use with AUD. It still needs some studies, but it has been looked at, it has been studied, and it does have some evidence, but still more studies can still be done. And semaglutide as well has been shown, but these are not yet used in human population for this indication. So now you've got folks made the diagnosis, got them started on treatment. How do you know how they are doing with the treatment that you have them on? At least you have to have some objective form of data apart from just what they tell you. So you can do some blood work to monitor how they're doing. And a lot of them we have here, from CDT to ETS and GGT to MCV and PET. Among all of these, PET seems to be the one that is standing out. So just to know, and PET can look back in the last 2 to 4 weeks how much someone have had to drink. It wouldn't tell you the exact quantity, but it can tell you if they heavy drinking or light drinking or things of that nature, or if they're drinking at all, maybe not even drinking. So that's what you can get from PET. So PET is what we use a lot to monitor treatment. And conclusion of my part here is, early screening and making the diagnosis and referral to treatment, engaging in treatment, and always be open to adding on some medicines to help with the therapy, as well as the counseling, because we have all of those options. And in the long run, this will all help the folks that we serve. And thank you.